All right, let's jump right in. Welcome to today's Explainer, a really high-yield, rapid-fire run-through of the trauma bay. We're going to break down 13 critical orthopedic scenarios that you absolutely must know inside and out. We'll be hitting high-stakes clinical vignettes and really zooming in on mechanical forces, neurovascular compromise, and rapid assessment matrices. So get focused because we're diving straight into the deep end here. Let's start right at the pediatric elbow. Picture this, a kid comes in after a bad spill off their bike, and they've got a classic extension-type supracondylar fracture. Now, when that proximal bone fragment displaces anteriorly, a very specific neurovascular structure gets put right on the stretch. So which nerve is the most vulnerable here?
The answer is D, the anterior interosseous nerve, or the AIN. If you visualize the path of the AIN right over that fracture zone, you'll see it literally takes a direct hit. And because it's a motor branch, the patient actually loses the ability to flex their thumb and index finger joints, meaning they physically can't make the OK sign. We also use the Gartland classification to figure out operative urgency, ranging from just a simple cast for a type 1 all the way up to operative stabilization for a really unstable type 4.
Okay, moving to an absolute surgical emergency. We've got a 24-year-old guy who was just in a car crash. He has a displaced humeral fracture, but look closely at the arm. It's pale, white, cold, and totally pulseless. This is a massive crossroad in the trauma bay. How are you managing this, right this second? Do you send him for a CT, an MRI, or an angiogram? You have to go with E, straight to closed reduction and percutaneous pinning. Delaying this for imaging is a huge pitfall because you're just prolonging warm ischemia time. The real issue here is that the brachial artery is trapped by the bone fragments. The perfusion triage pathway is super clear. A white, pulseless hand needs immediate reduction to unkink that artery. If it's still white after you reduce it, only then do you move on to open exploration. All right, let's shift gears and do a rapid-fire check on demographic baselines. This is basically playing the clinical odds. Question 1. What's the single most common pediatric fracture site? And question 2. What is the most common pediatric major joint dislocation? Lock in those answers. So the answers are the distal radius for fractures and the elbow for dislocations. This perfectly illustrates how unique the pediatric skeleton is. The distal radius is number 1 because kids' bones are super porous and elastic, which leads to those weird bending injuries like green stick or buckle fractures when they fall in an outstretched hand. On the flip side, the pediatric elbow is just incredibly prone to dislocation, especially in that 10 to 20 age range, simply because the joint is shallow and their ligaments are still pretty lax. Transitioning a bit further down the arm, let's look at a 23-year-old who fell off a bike. The X-ray shows a minimally displaced intra-articular fracture of the distal radius. What's our exact threshold for operating here? How aggressive do we need to be to make sure this young patient doesn't end up with debilitating arthritis 10 years from now?
The correct answer is A, percutaneous pins, supplemented with a cast. Since the fracture is minimally displaced, we really want to prevent post-traumatic arthritis by holding the joint perfectly still. But we also want to avoid the severe soft tissue trauma that comes with slicing the wrist wide open for a volar plate. So close reduction with percutaneous pinning hits that perfect sweet spot of mechanical stability.
Now let's consider a totally different demographic and mechanism. We've got a 58-year-old woman who slips and falls onto an outstretched hand, driving a huge compressive force straight into a hyperextended wrist. Given her likely osteoporotic bone status and that exact vector of force, what's the most likely fracture we're dealing with? Yep, it's E, the classic Cully's fracture. And this comparison matrix is one you absolutely have to memorize. That specific hyperextension load drives the distal bone fragment dorsally, giving you that pathognomonic dinner fork deformity. This is the exact mechanical opposite of a Smith's fracture, where falling on a flexed wrist drives the fragment anteriorly, creating what we call a garden spade deformity. Okay, so you've diagnosed the Colles fracture. You manually manipulate it, put it into flexion and ulnar deviation, and slide on a cast. What immediate iatrogenic threat, meaning a complication that we accidentally caused with our treatment, do you have to watch out for right after that reduction? You're looking at A, median nerve entrapment. When you crank the wrist into extreme flexion, which is called the cotton loader position, you're actually physically shrinking the volume inside the carpal tunnel. If the median nerve gets pinched and the patient complains they're losing sensation in their fingers, you cannot just wait and see. You immediately bivalve or slice open that cast and bring the wrist back to neutral to relieve the pressure. Drilling even deeper into the carpal bones now, let's talk about non-union, which is a complete failure of the bone to heal after 3 to 6 months. It's basically a localized ischemic disaster. Which of these bones carries a notorious, massive risk for ischemic non-union because of its really strange anatomical plumbing? It's D, the proximal pole of the scaphoid. The scaphoid's blood supply is incredibly weird. It actually flows in a retrograde direction. It enters distally and flows backward to the proximal pole. So if you get a fracture through the middle, it completely cuts off the blood flow to that proximal half, which leads to avascular necrosis. Oh, and here's a huge pearl. The scaphoid is part of the Flood's group. That stands for femur neck, lateral humerus, ulna, talus, and scaphoid. Commit those high-risk non-union bones to memory.
So, knowing how high risk the scaphoid is, let's look at a classic diagnostic dilemma. A pro goalie keeper comes in with highly suspicious snuffbox tenderness 10 days after blocking a hard shot. But the initial x-rays are perfectly clean. What is the ultimate highest sensitivity test to catch a hidden occult scaphoid fracture?
You're going to want an MRI. Now, a CT scan is fantastic later on if you need to plan a surgery and check cortical bone alignment, but an MRI is unmatched for detecting early trabecular bone edema. It can spot the injury within just 24 to 48 hours, ruling out an occult fracture with almost a 100% negative predictive value. Basically, if the MRI is clean, that scaphoid isn't broken.
But let's be real. You won't always have an MRI machine ready to go in the ER. Imagine we have that exact same presentation. A fall, exquisite snuffbox tenderness, but a negative x-ray. How do you actually manage that patient right now, before you let them walk out the door? You have to choose D. You rigidly immobilize that wrist in a thumb spica cast for 10 to 14 days. The golden rule here is, if the snuffbox is tender, you treat it like a scaphoid fracture until proven otherwise. The genius behind waiting 2 weeks is that it gives the body time for physiological bone resorption to happen right along the microscopic fracture line. So when they come back, that previously invisible crack will have widened enough to pop up clearly on a repeat x-ray. All right, shifting our focus from the bones to systemic neuromuscular grading. Let's talk about how we objectively quantify muscle strength. If a patient's muscle can actively move a joint through its full range of motion against gravity, but it immediately gives way the second you apply even a little resistance, what grade are we talking about? That is textbook grade 3 on the MRC scale, making C the correct answer. Let's quickly break down how the scale works. Grade 5 is your perfectly normal baseline. Grade 4 means they can take some moderate resistance. Grade 3 can overcome gravity, but nothing else. Grade 2 means gravity has to be entirely eliminated. Think of sliding a leg sideways across a flatbed. This objective grading is absolutely universal in trauma assessments, so know it cold. Moving down to the lower extremities now, we've got a 27-year-old victim of a road traffic accident. Honestly, even just standing in the doorway of the trauma bay, the sheer postural contour of their leg can give away a major fracture of the femoral neck. Which of these limb postures is the classic textbook giveaway? The answer is C. The leg will be externally rotated and visibly shortened. Here's why. When the femoral neck breaks, it completely uncouples the long bone from the hip socket, and massive muscle spasms instantly take over. The hamstrings and quads yank the leg straight up, making it look shorter, while the really powerful iliopsoas muscle pulls on the lesser trochanter, forcefully rotating the whole leg outward. A quick pearl to remember, if this were a posterior hip dislocation instead of a fracture, the leg would be internally rotated. Finally, let's look at one really specific diagnostic indicator. A 60-year-old falls. They've got deep bruising and swelling at the base of Scarpa's triangle, which is the femoral triangle. You ask them to sit in a chair and lift their leg, but they physically cannot flex their thigh because of severe pain from a fractured greater trochanter. What classic physical sign are we seeing here? The correct answer is A, Ludloff's sign. Because sitting relies almost entirely on the iliopsoas muscle to flex the hip, any tension on that avulsed trochanter makes movement completely impossible. Ludloff's sign is awesome because it perfectly isolates this specific fracture without even needing an x-ray to suspect it. Honestly, it serves as a stark reminder of just how mechanically fragile yet brilliantly interconnected the human skeleton truly is. So what does this all mean for you? Next time you walk into a trauma bay, how many of these split-second pathways and signs will you be able to instantly recall? Keep reviewing these concepts and I'll catch you on the next explainer.